Welcome and good afternoon, everyone. My name is Fadich-Tomsic, and I am the Vice President of Men's Health Network, a national nonprofit organization whose mission is to reach men, boys, and their families about the importance of proper men's health and guys getting more involved in their own health. And so we do that by reaching men where they live, work, play, and pray with health awareness messages and disease prevention messages through educational materials, patient advocacy opportunities, and patient navigation. We've spent many years working with the bipartisan Congressional Men's Health Caucus, currently co-chaired by Representatives Donald Payne Jr. of New Jersey and Mark Wayne Mullen of Oklahoma. We'd like to take a moment to thank them and the Congressional Men's Health Caucus for making this briefing possible. We're honored to have you in attendance today at this briefing to discuss men's and women's health and how far we've come in the past 25 years. Men's Health Week was passed in Congress in 1994, and 32 of the original co-sponsors are still serving in Congress. It was expanded to be Men's Health Month over a decade ago, while retaining Men's Health Week as a special awareness period recognized by Congress. There are over 400 Men's Health Month or Week proclamations from governors, mayors, and Native American communities at the Men's Health Month website. A bit of housekeeping. We are going to be holding questions. I think after each presenter, if you have a question or two, we can ask those questions, but we're going to try to hold all of them to the very end. As our congressional members come in, we will have them say a few words. So we already have one that's going to be coming up in just a second. And so make sure you write down all your questions. Mark Wayne Mullen is the congressional representative for Oklahoma's 2nd District, and he was elected back in November of 2012. He is currently serving in his 3rd term in office and serves on the House Energy and Commerce Committee, which oversees healthcare, energy, and consumer safety. Congressman Mullen.
Thank you so much. Look, first of all, I'm sorry about running in and out, and I'm not going to be able to spend as much time with you guys as kind of choose this. I'm not going to be able to spend as much time with you guys as I would like because we got a hearing going on, and I stepped out and ran. First of all, I want to thank everybody for being here and just kind of paying attention to what's happening. I mean, there's a trend that's taking place that is disturbing to me. You have men that are sons of someone that is a father to someone and a husband to someone that's committing suicide, or they're having acts of suicide by having a dependency on drugs, and they're accidentally overdosing and killing themselves on drugs. And what is that about? Why are we seeing that trend increase? And I was actually thinking about this last night because I got the fresh statistics, and I was actually concerned by it. And I thought, well, why is that? Because I fully expect to outlive my wife. I mean, I tell her that all the time, and she knows that. I'm fully going to outlive her because my family just lives longer than hers. And she says she doesn't want to live by herself, so I told her that she can go first, and then I'm going. But she has to die early because I'm not going to die of old age. And so I joke by it because death is something to me that is going to happen to all of us, but it's nothing that I look forward to. It's nothing that I'm anticipating or I think is the only way out. Because when you get to that point, because you feel like a failure. And you feel like a failure because there's no other hope for you. You can't control your life because drugs is controlling it. You choose suicide because you look around and you think the only hope you have is to end your life because everybody else's life behind you is going to be better. So how do you change that perspective? I think it starts every day. I think every day you have to choose to live a disciplined life. You have to have successes throughout your day. Whatever that success is, you have to have something that you've achieved every single day. It can be workouts. Mine, I work out regardless of what time I go to bed. I get up at the same time. I want to work out. I want to start my day exactly the same. I cannot walk away from my bed and it not be made. I can't even go to sleep without having my clothes laid out for the day before. In fact, before I end my day, before I go to bed, I have to put my coffee cup where all I have to do is hit the button. I have to lay out my clothes for the next day, including my socks, including my underwear, including everything that I'm going to wear. I have to lay it out every single day. When I pack per day. When I get up at the exact same time. I get up at the same time in Oklahoma as I do here, except it's an hour earlier according to my clock. It's just the same. I'm on a schedule. Because I've learned that I can only control my mornings, and I can't control the rest of my day, because the rest of the day there's so many things as an adult that you have to react to. But if I can achieve some things in the morning, I feel like that I've set myself up for success that day. If I'm walking down the hall and I see trash, I can't walk past it. I know it sounds stupid, but it's because I've learned to be disciplined by it. And if I walk past it, I feel like I have failed. I will literally turn back around and I'll pick it up and I'll throw it in the trash. I'm not that someone that can just kick trash closer to the trash can. I've got to pick it up. If I've got a gum wrapper in my pocket, I can't flick it out the window. I'll carry it in my pocket until I can go to the trash can. If I throw it to a trash can and it misses, I'm going to go over there and I'm going to pick it up. Because I want to live a disciplined life. It's not that I'm always disciplined. I've failed many times throughout my day, but I have a lot of little successes along the way, and it builds me up for success. And therefore, it allows me to have those times that I feel pride. When you get to the point to where you think your only way out is suicide, you've lost all that. You don't have to have big achievements in your life. You don't have to have big achievements all throughout your day. It's the little achievements. It's the little bitty marks of success. And if we're going to change the pattern to which we're behaving, if we're going to change this pattern right here, then we got to set the bar. Because if we're not going to change it for our generation, we got to change it for our kids' generation. I used to tell my managers that work for me in our companies that if you expect your guys to be here at 7:30, you need to be at work at 7. If you want your guys to be clean cut and be well groomed, then you have to make sure your clothes are starched, your hair is perfect, beard trimmed, and you got to have an extra change of clothes to you during the day just in case you get dirty. Because you got to set the bar high. If you want them to answer your phone call when you call them, then you got to be prepared to answer your phone call every time they call you. You've got to set the bar high. And we have to start setting that bar higher for the generations that's following us. Because this trend cannot continue. It's up to us. What does that discipline mark mean to you? What do you do to make sure that you're always living a disciplined life? If someone were to see you, would they say that you live a disciplined life? Discipline sometimes is called structure too. There's nothing wrong with that. Because I've achieved something. When I live a structured life, I've achieved something. It was John C. Maxwell that said in the 21 Irrefutable Laws of Leadership, he said, discipline for a leader is doing something every single day that doesn't necessarily need to be done, but needs to get done. That means that that trash doesn't have to be picked up by you, but someone's going to have to pick it up. Right? It means the little bitty things, that's discipline. And that's also success. So all I'm doing is just simply encouraging you guys to change our behavior so this trend here can go away. Because someone's watching you. And they're going to say, I want that out of life. I want that. If he can do it, there's nothing special about him. And if he can do it, then I can too. We're all created equal in God's eyes. So it starts with us. Right? Guys, thank you for you paying attention to it. Hopefully you'll get the air in here because it is hot. But if there's ever anything I can do, I'm all in. I'm involved in it. I have been involved from day one since I've been up here. So thank you once again. Look forward to working with you all.
going to get right into our presentations. Our first presentation is Dr. Renee Gindy. She received her PhD in epidemiology from the Johns Hopkins School of Public Health. Renee is the chief of the Population Health Reporting and Dissemination Branch in the National Center for Health Statistics Division of Analysis and Epidemiology. That's a mouthful. All right, let's get our presentation up.
While we're getting that pulled up, I just want to express my appreciation for the invitation to join you here today. It is my pleasure to be here, and I'm going to be talking a little bit about, sorry if you can't see me from over there. I'm going to be talking a little bit about life expectancy changes among men and women, and giving you a look behind the numbers. Very often, probably you've picked up reports and you're getting these health terms or statistics, and you might have wanted to know a little bit more about them. So we'll be going through a little bit of the nitty-gritty on those today, and then I'll also be giving you some of the recent changes in statistics. So before I get started, I do want to emphasize that while I am from the Centers for Disease Control and Prevention, I am also from the National Center for Health Statistics. If you're not familiar with our work, we are one of the 13 federal statistical agencies, which means that our job is to provide all of you with authoritative and official health statistics so that you can make the choices and decisions about health policies and programs. Our agency does not advocate for any of the policies and programs in particular. I leave that to all of you in the room and, of course, my esteemed panelists today. So today I'll be talking about changes in life expectancy, death rates, changes in death rates that have contributed to those changes in life expectancy, and leaving you with a little bit of information about the leading causes of death. Most of the information that I'll be talking about today comes from a report that's actually in your folders right now. It is Health United States, and that is a congressionally mandated report on the trends in the health in the nation, and it's been published by NCHS almost continuously since 1975. Now, I'll be focusing today on statistics on health status and determinants, but we're mandated to cover many other areas. So if you're looking through that report and want to know more about trends in, let's say, healthcare utilization, we have information in there, healthcare resources, and healthcare expenditures and payers. I definitely encourage you to go to our website. That report is just a small fraction of the material that we have available. So we have plenty more online. You don't need to be able to see the details on this graph. The main reason that I have it up here is for three main points. What is life expectancy anyway? Life expectancy is an overall measure, a summary measure of population health. And what's important about it is that it's one number that actually allows us to compare health status potentially over populations, or over different groups, or over time. And so all this graph is telling you is that the US in the red has a life expectancy from 2015 of a little over 78 years. But all those other countries from the OECD to the right of us have higher life expectancies than we do. Another feature that you'll be seeing throughout this talk and in some of the other talks is that there's actually a gap in average life expectancy at birth between women and men. Women in all of these countries have higher life expectancies than do men. So let's talk a little bit about what life expectancy is and what can impact it. Average life expectancy at birth it's actually a little bit of a modeling exercise. Imagine, if you will, a baby born today. And then imagine that the death rates that exist today stay constant throughout that child's entire life. What is the age at which we expect that newborn to live if those death rates are held constant? So one way that I can maybe give you a little bit more of a feel for this is in 1900 in the US, life expectancy at birth was 47.3 years. Now, what happened in the first 50 years of the 20th century? We had improvements in sanitation and hygiene and the introduction of antibiotics and the implementation of vaccination programs. And 50 years later, the life expectancy at birth had increased by about 20 years. So in 1950, a newborn born in that year would be expected to live to be 68.2 years old. So life expectancy at birth is one kind of summary measure of health statistics, and age-adjusted death rates are another kind of measure that is a summary of the health status of the nation. And they have a little bit of an inverse relationship. You can see that as those age-adjusted death rates come down, the life expectancy is going up. But what is age-adjusted death rates? Why can't we just use death rates? Why can't we just take the number of deaths over the total number of the population? Wouldn't that be a more fair comparison? Well, the same way that life expectancy is that summary measure that allows you to compare across populations or compare over time, age-adjusted death rates do the same thing. And so for one example, we can show the population pyramids from 1975 and 2015. We, again, don't need to get into the details, but what you can see is back in 1975, we had a much younger population. For the most part, there were many more people who were between the ages of, let's say, 10 and 30, and fewer people who were over age 65. Whereas by the time we hit 2015, that proportion that was older had actually increased quite a bit. And so if we just compared the death rates from 1975 to 2015, all we're doing is comparing rates that say, well, we've got an older population in 2015. So what do we do when we are adjusting for age? We actually take a standard population, right? So many of the standard populations in our report use the US Census from 2010. And we will take the population from 2010, and we will take the death rates from, let's say that was 1975, and apply them to a 2010 population. We'll take the death rates from 2015 and apply them to a 2010 population. We remove the effective age of the age structure of the population so that we can make real comparisons between those two groups, between those two times, and actually have an understanding of what the health status of the nation is. Now, you may have picked up a report in your time here where you've gotten an age-adjusted rate for 2017, but it looks different from an age-adjusted rate for 2017 that you've seen elsewhere. Why on earth are those numbers different? Don't panic, just read the footnotes, because there's actually a very good chance that that someone was using a different standard population. And so as long as you're using the same standard population, those estimates will be similar. But now that I've given you a little bit of an understanding of where these numbers are coming from, let's look at the numbers that the Congressman was just talking about. So life expectancy at birth has been decreasing since 2014. And you can see in this graph the same thing that we were seeing in the OECD figure that compared across other countries. Women generally tend to have a longer life expectancy than do men. And one of the things that we've been hearing about in the news is that since 2014, those life expectancy estimates have in fact been coming down. Now for women, there was only one significant decrease between 2014 and 2015, and those rates have held constant still since then. And for men, those rates have decreased each year since 2014. If we break it down by race and ethnicity, we see a very similar pattern. For men, Hispanic men have the longest life expectancy, but we're still seeing those decreases each year. Same for non-Hispanic white men and non-Hispanic black men. And for women, we have that same sort of pattern where we were seeing an initial decrease between 2014 and 2015, whereas those decreases have leveled off among each of those racial and Hispanic origin groups. But again, remembering what we said about life expectancy, that life expectancy at birth tends to increase when we have big changes, or actually even small changes, among our youngest age groups. So one of the things that we did to explore these decreases in life expectancy is look at the changes in death rates for all causes, just thinking about deaths for everything. And what we found was actually significant increases during that time for age groups we weren't expecting, 15 to 24-year-olds and 25 to 44-year-olds. And if we break those down a little bit more, we start to get into understanding the statistics that we have seen in the news and in other reports. When we look at the leading causes of death for men in this youngest age group, thinking about what has actually been on the increase, we see significant increases in homicide, suicide, and unintentional injuries. Now, unintentional injuries can sound just like accidents or motor vehicle accidents, but also includes those accidental drug overdoses. So obviously that's something that everyone's concerned about. We see a similar pattern for young men aged 25 to 44. Homicide, suicide, and unintentional injuries have some fairly steep increases, as well as another cause, chronic liver disease and cirrhosis, which is a chronic, can be have a risk factor of chronic alcohol use. We see similar patterns for women, although I will note that the scale's a little bit lower here. So we are still seeing among women in these younger age groups increases in homicide, suicide, and unintentional injuries, and again, the same pattern for women in the age group of 25 to 44-year-olds, where we start to see an increase in chronic liver disease and cirrhosis. And of course, if we want to even more go into the increases in unintentional injuries, we can also focus on drug overdose rates. This is actually something that's in the report that you have in your hands. The drug overdose death rates for men age 15 and over, what we found was that these drug overdose death rates were increasing and increasing fairly steeply for again, the younger men, age 15 to 24, 25 to 34, and 35 to 44. But I will note that this occurred in all age groups. And we saw the same patterns among younger women, and again, increases among all women. I don't want to leave you thinking that the only influence in the decreases in life expectancy were unintentional injuries and suicide. I will also call your attention to heart disease and cancer still being the leading causes of death in the US. And while heart disease deaths have been on a general decline, those declines have actually stalled out since about 2011. So again, my main takeaways today are life expectancy has decreased in recent years among men and women, although there are differences by sex and race and Hispanic origin, and that those decreases have really been driven by changes recently in age-specific death rates. Thanks.
All right, do we have any quick questions for Dr. Gindy? Okay, we are going to move on to our next presenter, who is Dr. Jean Bonhomme. Dr. Bonhomme earned an MD from State University of New York at Stony Brook, and in 1987 he founded the National Black Men's Health Network. For decades he's been recognized as an expert on minority men's health, and he's a professor at Morehouse School of Medicine.
Okay, good afternoon, everyone. As we've discussed, the overall U.S. life expectancy, while lagging behind a lot of other countries, there's currently a gender difference between males and females of about 5 years. It was a little smaller than that a few years ago. For white males and white females, the gender difference is 4.9 years. For black females and black males, it's 6.1 years. Now, one of the questions that's been raised recently, Dr. David Sinclair at Harvard is asking if there really is a limit to human life expectancy. We don't know, for that reason, we don't really know whether the gender differences really represent a limit to life expectancy. One of the things that has happened that has lowered mortality, for instance, for men with prostate cancer, the mortality rate decreased from 39% from 1991 to 2008. Now, one of the things about prostate cancer is that it rarely has any symptoms in the early stages. Urologists who I work with talked about in the 1980s when he got started, the typical way that prostate cancer would be detected would be a man would come in with a severe backache, and by that time it will have already spread to the spine and would be basically untreatable, except palliatively. When the PSA, prostate-specific antigen test, was introduced in 1991 to 1992, it is not specific for cancer. It can be high because of an infection. It can be high because of enlarged prostate, but the fact is it gives it an early warning. There has been some debate about whether it should be used routinely, but the fact is that it is felt that it did have an impact. Another thing that had an impact, according to this researcher, Ruth S. Stoney at HHS, is that improved treatment has also been a factor there. Now we have, in addition to things like radiation and surgery, there's cryotherapy where they can freeze a tumor, there's high-intensity focused ultrasound where they can use ultrasound to burn a tumor. So the point is that we have better treatment than before. So the prostate cancer mortality has been declining owing to screening and treatment. Now, cardiovascular disease had been declining steeply, 3.5% to 4.5% yearly until 2014, but then afterwards it started to go down by less than 1% per year, but it had been going down 3.5% to 4.5% per year. Cancer had been steady going down and is continuing to go down, the mortality rate at about 1.5% per year. But the slowing of the decline in cardiovascular disease, for some reason, it's occurred in males, females, all races and ethnicity groups. Males have had higher mortality rates for females for both heart disease and cancer. Non-Hispanic blacks having the highest mortality for cardiovascular disease and heart disease in all years, followed by non-Hispanic whites, non-Hispanic American, Indian, Alaskan Natives, Hispanics, and finally non-Hispanic Asian Pacific Islanders. And again, the rate of decline of cancer mortality has remained relatively stable. The opioid epidemic. I worked in drug treatment for about 35 years, and basically it has now been compared to the AIDS epidemic of the 1980s. I think very few people here are old enough to remember that, but it was a really terrifying thing when we had a disease that we didn't know how to detect, and people were dying from it. We didn't know who had it until testing was invented, and then for a long time we couldn't treat it adequately. But annually, more people die from overdoses, primarily opioid drugs, than died in the entire Vietnam War, the Korean War, or any armed conflict since the end of World War II. It's estimated that 90 Americans died daily from an opioid overdose. From 1999 to 2011, the mortality rate of opioid-related overdose increased almost fourfold, and the rates of emergency room visits increased by more than 200%. Neonatal abstinence syndrome is babies being born addicted, and opioid use disorder treatment admissions have also increased greatly. Death rates are highest among males under age 50. In Massachusetts, men aged 18 to 34 had opioid-related deaths rates nearly 3 times that of women of the same age. Most people who reported prescription opioid misuse initiated the use in the early to late 20s. Overdose deaths can be misclassified. Sometimes we tend to classify them as accidents, but sometimes there's suicidal intent that we don't know about, especially in older adults. And it's further complicated by the increased availability of heroin. Around 2000, prescription pain pills took the opioid market away from heroin, but now heroin is cheaper. And in treating drug addicts, I would often find that they were using the heroin because they could get it easier than they could get the prescription pain pills. Another factor that's come on that these researchers were not able to consider is that now we have the opioid analogues like fentanyl. They can be made in labs, and sometimes we have fake pain pills that fentanyl has a potency about 80 times that of morphine. So if it's not cut precisely, even seasoned addicts can die of a fentanyl overdose. And about 80% of current heroin users reported that they began with prescription opioids, and that's consistent with my experience in drug treatment. A lot of people who never used drugs or never smoked developed a pain condition, whether it was from an auto accident or whether some women had endometriosis and had severe pain. So one patient had a melanoma removed and was left with a severe scar that was painful, but they may start with prescription opioids and then be unable to get off. So a lot of it begins with prescription opioids. When you see a person addicted to opioids, it's not necessarily that they became addicted recreationally. They may have become addicted because they had a painful condition and they were left on it too long without being tapered. 200% increase in opioid-involved overdoses took place from 2000 to 2014, according to Rudd, and a 3-fold increase in heroin-involved overdose deaths from 2010 to 2014. Now, U.S. suicide rates. The suicide rate has increased 33% from 1999 to 2017. It was originally 10.5 to 14, and increased to 14 suicides per 100,000. And from 2000 to 2016, for white Americans, 11.29 to 15.7, and from 5.52 to 6.03 for black Americans. Now, black Americans are typically thought of as having a greater homicide rate but a lower suicide rate. But one of the things about suicide in black Americans is it typically involves younger people. The usual demographic for someone who commits suicide would be an elderly or middle-aged male who might be in poor health, might be isolated. With African Americans, it tends to be the younger men who are taking their lives. Suicide is the fourth leading cause of death for people aged 35 to 54, the second for 10 to 34-year-olds, and it's the 10th leading cause of death overall. What are the risk factors that predispose to suicide? Depression, substance use disorders, mental illness, poor physical health, chronic pain. The means of suicide, if you have access to a means that's very lethal, guns and ropes tend to lead to suicides that are completed, where overdoses might not. Divorce, unemployment, relationship problems, finances, previous suicide attempts, family history of suicide, and a history of childhood abuse or trauma are risk factors for suicidal behavior. And suicide rates tend to fall when socioeconomic conditions improve. They said that Ann Case and Angus Deaton have found that deaths from suicide, drugs, alcohol have risen steeply among white middle-aged Americans since 2000. They seem to be being displaced, especially the ones without college degrees. They seem to be displaced in the employment market. And they call those the deaths of despair. And suicides have increased most in rural communities because of loss of farming and manufacturing jobs with resulting economic declines over the past 25 years. So we've made progress in certain areas. We have less cancer deaths. We have less cardiovascular disease deaths, which are the two leading causes. However, we've had other things coming up with in terms of suicide and the opioid crisis. Now, the gap in life expectancy between the genders has not been fixed. In 1920, it was only 1 year, and then it gradually widened. About 1970 to 1980, it became its widest, and now it stands at 5 years. Now, people ask about, why is it that women outlive men? It might be a better question to ask, why did the increase in life expectancy that took place over the course of the 20th century for men, why did it not keep pace with the increase for women? Did we do something differently? Is our outreach, is our intervention different? We need to consider that because it appears to fluctuate. This slide I found really compelling, and it's really surprising to me because if you look at this is the excess mortality in males by age. It is greatest in the 15 to 24-year age group. Now, if the difference in life expectancy between the genders is innate and biological, why is it the lowest in infancy and old age, where you would expect biological effects to be the greatest? The frail elderly and the infant is biologically more vulnerable than the 15 to 24-year age group, where we get our Olympic athletes from. The fact is, what's causing the deaths is something that probably doesn't have that much to do with biology: injuries, suicide, drug overdoses, things of that nature. But these are things that we can potentially change. A study that's available online, David Sandman, Out of Touch American Men in the Healthcare System, found that men in the 18 to 29-year age group were the least likely group to have seen a doctor in the past year or have a physician. I was talking to some women professors at Morehouse School of Medicine, and they offered to me that as girls they were treated by the pediatrician, but as soon as they became old enough to be considered women, they were given to the OBGYN, the gynecologist, for continued care. For young men, the health care drops off the face of the earth once they get past the pediatric age group, which is a shame because in the 20 to 29-year age group, we have hypertension and prehypertension, we have high cholesterol, we have diabetes and prediabetes, we have overweight and obesity, and when men start seeing the doctors more in their 40s, 50s, and 60s, but if you've been sick with high cholesterol, with high blood sugar, with high blood pressure for decades before you see a doctor, the prognosis is very different because there's already been significant end organ damage. So the point is that boys not being connected to the healthcare system in the 18 to 29-year age group is an area that we need to rectify. And some people say that we need to try sports medicine or some other way to continue health care for males after the pediatric age group. Also, men are taught to be stoic. When a boy is 8 years old and he skins his knee, they tell him brave boys don't cry. When he gets hurt playing high school football, they say take one for the team. When he's 50 having chest pain, he says, oh, that's just indigestion, because he's been taught to ignore his body. So less than 20% of males stated that if they were in pain or sick, they would seek help promptly. 24% said they would delay as long as possible. 17% said they would delay a week or more. So the point is that we need to look, men are more performance-driven. If you tell them this will make you work better, this will make you more attractive, this will make you stronger, if healthcare is marketed to men as something that improves performance, it'll probably be more attractive to men. Now we need to, why have men's health in the first place? We need to consider the effect on spouses and children. My next door neighbor called me in 2002, unable to wake her husband, and I went to see him, and he seemed to be conscious but unable to speak or coordinate his movements. Turns out he had a stroke, and he had signs of it months before that were not picked up. But she lost her companion of 32 years. If he had survived a stroke, she would have had to care for him the rest of her life. When a man becomes disabled, who has to take care of him? Her family, her earnings are diminished. She has trouble affording her house. A woman who loses her husband, her all-causes death rate doubles in the month after. So, and older women don't typically have good prospects for remarriage. And in disability, a family may face increased health care expense in the face of diminished earnings. So you have less money but more costs. And the economic effects on society of male illness and death: lost time from work, diminished work productivity, a provider may become a dependent, a taxpayer may drain the tax system. You may be not quite disabled but have difficulty maintaining gainful employment. I worked with a physician with rheumatoid arthritis. When he got up in the morning, he was so stiff he couldn't come in and see the patients until he had worked his joints, and that's typical of arthritis. So the point is that you might not be, you're not exactly disabled, but your ability to work is limited. Poverty is associated with widowhood. Children face these repercussions as well. The way I feel about men's health and women's health is that you can't effectively weed half a garden. You have to treat all of the garden or the weeds will just grow back. And some people think that men's health and women's health are like opposite ends of a seesaw, that if you give to one, you have to take away from the other. I think exactly the opposite is true. I think if you don't address both, you can't fully address either, because the genders are interactive and interrelated. So men's health is a vital but often overlooked aspect of community health. Our rising tide lifts all boats, so if we pay more attention to men's health, we can improve the health of both genders and achieve optimal overall health in our communities and in the nation as a whole. We need to look at a tetrad approach between co-equal partners: children's health, women's health, men's health, and minority health being all addressed so we can optimize health everywhere. Thank you.
Great. Thank you, Dr. Bonhomme. Our next presentation is by Heidi Rosvold-Brenholtz. She is a Senior Vice President for Strategic Engagement, Policy, and Science for Healthy Women. Her primary task is to educate healthy women's audiences about policy issues and decisions that impact their health and their communities. And she's a founding partner of Healthy Women.
Hello, everyone. So my role here today is slightly different than my fellow esteemed panelists. I will not be engaging much in statistics or epidemiology, although these numbers thrill and frighten me both. My job is to talk about women's health and this 25-year progression of promise and progress. Our time machine target is 25 years, but I'd like to turn the dial, or I should maybe say adjust the digital button, back just a little bit further to include a 30-year time frame. It's both amazing and astounding to me to consider the accomplishments across policy, research, clinical care, and advocacy for women's health during the past 3 decades. A time in which Healthy Women, formerly the National Women's Health Resource Center, was born and grew up with what I like to call our sister organizations, the Federal Offices of Women's Health at the HHS, the FDA, the NIH, and soon after, in 1994, the CDC, and a number of other consumer, patient-focused nonprofit organizations, all with the goal to advocate, research, and invest in the unique needs of women's health, among other needs where a population is concerned. It's amazing because of the positive impact this progress has had in advancing women's health, and by extension, the health of our families and of our communities. It's also astounding because it seems like such recent history, right? For many people here in the room, some of these milestones occurred before you were born, but it's still a very small window in time. There's so much more to be done and so many more promises to keep. In 1988, the National Women's Health Resource Center was created at Columbia Hospital for Women by an obstetrician-gynecologist named Dr. Violet Bowen-Hugh. She was a women's health champion, and she recognized that women needed resources to help them overcome knowledge barriers where their health was concerned. Our organization was founded on 2 very simple concepts: independence and advocacy. Women wanted and needed health information to understand and manage their health, information that they weren't getting or couldn't get from their healthcare providers. Number 2, women would use resources, Dr. Violet Bowen-Hugh knew, if they were easily accessible, easy to understand, and spoke to women directly to advocate for their healthcare needs. We also recognized that women wanted health resources on topics beyond their reproductive health needs. At Healthy Women, or the National Women's Health Resource Center at that time, this meant providing women with accurate, objective, and comprehensive resources, developing, individualizing, and delivering this information. We provided personal support. We actually picked up the phone, or we responded by mail to women's most personal and complex questions in these pre-internet days. Questions ranged from things like, how does my menstrual cycle work? I'm afraid that there's something wrong with mine or with me. Where can I learn more about silicone breast implants and the dangers to my body they could pose? How to recognize a heart attack symptom or a stroke symptom and how to tell the difference? How to treat or where to get a diagnosis and treatment for specific sexually transmitted diseases. Early in our history, we recognized that we could improve the dialogue healthcare providers were having with women, or most likely not having. We reached out to a broad range of providers and created consumer health-focused, we purged the word patient in a lot of situations, consumer health-focused information for healthcare providers to distribute in their offices or use as primers themselves for their conversations with their patients. Healthy Women continues to meet women's needs today by tailoring health information and creating a personal experience for our more than 1 million visitors a month on average to our website. The first women's health resource on the internet. Women healthcare providers, the media, and our many partners from sister organizations, federal agencies, industry, and even the Men's Health Network know Healthy Women is a trusted source for women's health information and a committed partner to advancing women's understanding of their health and thus improving their health care. I'm going to go quickly through a couple of milestones thanks to a timeline created by HHS. Just to give you an idea, this snapshot in time of things that happened in the last 25 to 30 years. Between 1988 and 1989, the DEXA scan was approved for clinical use to diagnose osteoporosis. Manufacturers were required to submit safety and effectiveness data on breast implant products or withdraw them from the market. Between 1990 and 1995, the National Breast and Cervical Cancer Early Detection Program was established, and the Violence Against Women Act in 1994 put domestic violence on the map as a major public health issue. Women needed to understand what these advances in research, in science, and advocacy meant to their health. And that's where Healthy Women came in, to develop information to help women explore with their healthcare providers, explore with their families, what they should be doing to keep themselves healthy or to address specific disease and condition information. Between 1996 and 2001, the first of 6 National Centers of Excellence in Women's Health was established by the Office of Women's Health at HHS, providing nonprofit organizations with new partners and resources, again, to share with women and their families about their health. The breast cancer prevention trial and the study of tamoxifen and raloxifene, the STAR study, was a major advancement. It demonstrated that half of breast cancers can be prevented with a medical intervention. It provided a new paradigm and provided a preventive option for women where none existed before. Between 2002 and 2007 was the oral contraceptive and breast cancer study, which showed no increased risk of breast cancer with oral contraceptive or HRT use, hormone replacement therapy. There was also the Heart Truth campaign that began to open our eyes to the differences in women where heart disease symptoms were concerned. So where are we now? The progress. The consumer health information revolution, which I've outlined a bit of today. Women are getting more information, they want more information, and I think we're improving their health with more information and the health of their families. Women are the CEOs of their families, healthcare needs, and communities benefit from women as informed healthcare consumers. Fact of life, women's health is broader than their reproductive health, with focus on aging well across the lifespan. Another hugely important piece of progress, the Affordable Care Act and access to preventive health services at no cost. It improved health care for women and importantly for women of color, with increased rates of health screenings, including mammography, cervical cancer screenings, and access to primary care providers. Another example of progress is identifying the impact of chronic disease and of particularly the effects of chronic disease on communities of color. Number 5, Viagra. Because this is a briefing with the Men's Health Network. Viagra helped put sexual health on the map. And for women, there's a long way to go, but it helped evolve the focus on the importance of sexual health dysfunction in women's health. Promises, I'll go through them quickly. I have 5 for the future. Affordable health care and access to care needs improvement. It needs to be front and center of everyone's mind. Shorter time to treatment and accurate diagnosis for conditions such as fibroids, endometriosis, depression, and heart disease. Women are waiting too long to be treated and effectively diagnosed with interventions if they exist. Improved maternal health, it's a major crisis in America. We're the only industrialized nation with a rising maternal mortality rate. There are a lot of known reasons, and there are a lot of unknown reasons for this statistic. Viagra, again, improved treatments for sexual dysfunction in women is a big need, and we need more investments in women's health where sexual health is concerned, and improving safe and effective pain management, to the points about trying to understand and get control of the opioid use disorder epidemic in this country and its unique effects on women and their communities. Thanks very much.
All right, thank you so much, Heidi. We do have Congressman Payne Jr., who has joined us today. So Congressman, if you want to make your way up here, please. He is a Democratic congressman representing New Jersey's 10th Congressional District, which covers portions of Essex, Hudson, and Union counties. He is chairman of the Homeland Security Subcommittee on Emergency Preparedness, Response, and Recovery. So we invite you to say a few words. Just be careful there.
This work? Good afternoon. It's a real honor and privilege for me to be here. I apologize for my delay. I believe I was supposed to give open remarks, but it looks like these are closing remarks now. So I just delighted I was able to get here from a committee hearing on transportation. But really want to thank all of you for being here today, especially to our esteemed speakers who have come to discuss topics that affect every person in this room, our health. Also want to acknowledge the Men's Health Network for their tireless efforts to promote men's health. Oftentimes, we may find ourselves guilty of letting our health go. It becomes something that we put to the back of our minds as we become progressively busier, more preoccupied with the day-to-day happenings than we are with our long-term health. At times, this gets the best of us when we put off doctor's appointments or going to the gym. However, I'm a firm believer in the progress and the promise of a better tomorrow. We have some of the best and brightest minds working to find cures for even the most complex ailments. Our screening processes today are quicker and less invasive than ever before, able to catch diseases earlier and earlier. Equally as important, however, is what we do. Our personal health starts with us, first and foremost. Healthy living is not simply a one-time commitment. It is the formation of habits that require a conscious effort, one day at a time. It is never too late to start forming healthier habits. I am living proof of this, believe me. My hope is that the information we learn today will inspire us all to form a new, healthier habit, try out a new recipe, take stairs, get enough sleep, and things to that nature. Forming a new, healthier habit may look different for everybody in this room, but by gathering here today, we all have one thing in common, a commitment to longer and happier and healthier lives. And I mentioned that I am living proof of that. I am what I used to call a 25-year non-compliant diabetic. And, eventually that catches up with you. And over the last 4 years, I've suffered from a multitude of ailments attributed to my diabetes. I won't go into the long list, but believe me, I've had my challenges to the point where in January, my kidneys failed and I'm on dialysis now. So, I've been talking about my story, and I'm chairman of the co-chair of the Men's Health Caucus in the Congress, and I think I got the job because I'm the most infirm member of Congress. So, I was the right guy for the job. But, we continue to try to promote healthier lifestyles along with John Wayne Mullins, who is my co-chair. And, just want you to know that it is imperative that we continue to try to strive to be healthier. I'm kind of saying it after the fact, but I've learned now what I needed to do earlier on in order not to be in the circumstance that I am now. But my life's not over yet either. So in my dialysis, I talk to people in that space and let them know that, this is not a death sentence. Our life isn't over. can live. I feel better than I have in the last 40 years, to be honest. I continue to try to preach that, and I'll do everything I can to support the efforts of everyone here and everyone in this room. So, thank you very much.
All right, moving right along, we have David Johnson, who is Operations and Management Officer in the Office of Population Affairs in HHS. He's responsible for the program management of several national grant programs administered as part of the National Title X Family Planning Program. Just get your slide up.
Well, good morning, or actually it is afternoon, sorry, that's where the day's gone, I guess. So thank you all very much, and again, I apologize for my delay. I had to oversee my director get kind of grilled on the Hill and Oversight Committee, so it was quite the experience. So this is a much friendlier, happier bunch of faces, so thank you for that. So part of, I guess, what I want to talk about, what really are some of the government initiatives? So I'm in the Office of Population Affairs. We administer the Title X Family Planning Program. So I think a couple speakers already talked about kind of the involvement of women's health and that overlap. And I think when we think about family planning, I will say this as a proud 15-year employee in federal Fed within the Office of Population Affairs and Family Planning, is that it is directed at women. When we think about family planning, we think about reproductive health. Not only the burden, but the opportunity that presents itself. And when in 1970, when the program was actually developed and signed into law, that's what the concern was, right? How to provide better services to those who need it. And at the time, those who were identified as being in need primarily were women. However, Congress does do things right every now and then, and not to offend anyone who is actually a sitting member of Congress right now, they also made sure to incorporate that the services under Title X were both for men and women, males and females. It was very clear of their intent. So going forward, it took us several years, several decades, to actually get kind of an idea of what that meant for males. We had men who actually males, and I'm going to use the term interchangeably, but so for the males that were actually going to receive services, part of the issue was, where are they going? What does that mean? Again, what are services for Title X, what are family planning, reproductive health services? And when you think about general overall health, we have to always ask that question, what really are the needs that present themselves? So as we get through a lot of different decades, and we finally came to the end of the 90s, mid-90s, we thought about what does the Title X Family Planning Program want to do? How do we want to increase opportunities, most likely specifically access, which also means, in a separate sentence, reducing those disparities, reducing those barriers that are there, and educating individuals. Not only just us as clients, as individuals receiving these services, but also providers, administrators, those that actually help manage our access to healthcare. So that's just a kind of a brief status kind of where Title X is. I think one of the things that we want to look at, and speaking a little bit broader at the government level, what does a program that addresses male health, what is it supposed to be? I am going to twist it to a little family planning because that's kind of what I do. But I don't think it's something that we should, that we have to be just set on. So one of the things that I think about when we look at that is, what is our role? One, establish policy. What is the guidance that we can not only come up with, take those research, take those data that are out there, combine that into words, combine that into action to help inform and support services and existing, but also future programs. So taking policy at a very high level, but need to be informed by everyone that is here, but also those that I guess our clients, right, our customers. And I'll use kind of interchange, we think about business-wise, right? Who are we trying to meet the needs of? And what are those needs? For me, it's not to define those needs. And I think from the federal side, yes, we all have our appropriation, we all have where we're funding from, what our goals are. But when we think about the needs, think about those at a very general level. So when we think about policy, how does that policy inform kind of that action? Second part of it, I think, in looking forward is, what are those outcomes that we're trying to achieve? And for me, it's health outcomes. Those health outcomes are both direct and indirect. So are we meeting those needs of the individuals that are there? Are we also able to inform through that policy, through our programs, and then through the third piece that I'll get to is guidance, but are we able to achieve those needs that they're presenting with as well as help anticipate and or bridge potential access in the future for those needs that have not been developed yet. Right? What are those things coming down the line? If we think about trying to provide health care across the lifespan, across generations, right? Where we are at 20, where we are at 6 months, right? We can use whatever cutoff point we have to be. We all have different needs. Whether or not that need is being identified by us, and certainly before about 10, it's not really being identified by us, or not often. As we start transitioning later, it gets into possibly us identifying those needs. And I think as my colleague here identified, at some point it is our partners who are identifying those needs for us, whether or not because we know that they are, or whether or not we want to. So in the long run, what we're trying to find out is how can we impact that need, that identify change there, again, guided by policy, as well as help set up that down the road. So for us in Title X and family planning, a male probably is coming for, most likely a male is coming to our centers for a symptomatic STI, right? If we think about why would you show up, yes, we have wonderful men that are coming and are looking proactively, and how do I help my partner help plan our pregnancy and or prevent a pregnancy that we're not ready to quite have yet. But let's just take, for instance, having that access to a symptomatic STI. One of the things that we think about, we'd like to treat that. We can treat those. The majority of those we can treat right there, come back. What we also want to set up, and again, through guidance, through mission, through goals, through data, is to ensure that they either come back to us when they have that existing need, or they feel comfortable, and we hope they feel comfortable going to another healthcare provider, whether or not it's in the family planning setting, or if it's in primary care, or someplace else. So again, for me, policy is wider reaching. As the federal government, we have an obligation not only to do what we are paid to do through our appropriation, but also when we think about our mission needs to be broader than just exactly what we do. Or we continue to run in those silos that we unfortunately have to have to one degree, but we are not required to stay in there. So the final thing I think is guidance. So when we think about guidance, how do we support both that policy? How do we support that mission, those dollars that go there? How do we continue to inform? Policy is, once it's finalized, it doesn't change very often, for good and bad. But guidance needs to continue changing. When we think about this, and again, because I came in late, I had the opportunity of hearing the impact of medicine, and we talked about Viagra, right? What is the impact that had? Ideally, everyone's going, oh, well, that just helped individuals and men with erectile dysfunction, or in a certain that needed to happen. No, the impact of that was much farther reaching. So when we think about those direct outcomes, I think that's an awareness that government has to have, the direct outcomes. Treating that acute need, or the identified need that might not technically be acute, and also anticipating what that indirect outcome was. For us, we want to make sure that when an individual comes in for services, acute services, whatever the services that are, that we also bridge that gap between relationships. In family planning, it's about relationships, whether or not it is a partner, it is a temporary partner, an occasional partner, a bound partner, whatever that relationship is. It's also for us to be able to ensure that through that guidance, through that clinical delivery of services, whatever our mission is that we help make that bond. And part of that is through that communication. What is that guidance? What is those research? What are those data? What is the research? And what is the other literature that helps us support that? So in the long run, I think from a government standpoint, as we all sit in the hallowed walls of government legislative branch here, how do we best foresee the issues that we have, given our unfortunate, and I say that the resources, we're bound by resources, we're bound by time, money, and again, we sit in the legislative, I'm not in the legislative branch, so I can kind of dog them a little bit today, but right, there is a game that has to be played, so we just have to be farther reaching. So I think I have come up to my time, so I appreciate the opportunity, and thank you.
Thanks, David. All right, our final speaker is Andrew who is the Director of Public Policy and Government Relations for Patient-Centered Outcomes Research Institute, also PCORI. So I'm just going to give you the mic and let you start. Give you some time.
Great, thanks, Anna. Thanks, everybody, for sticking around, and good afternoon. I learned a bunch today, just sitting here, so I'm glad to go last and kind of do my best to reflect back a little bit of what we heard today and why it's useful to have this discussion, and also hopefully reintroduce, but most likely introduce you guys all to the Patient-Centered Outcomes Research Institute, or PCORI. But one of the things that I think we're all here today is talk about, why do we need to have these discussions in the first place, right? Because obviously our healthcare system is unique. It's got its pros and cons, as I'm sure you guys are all aware and dealing with every day. And one of the things that we all want to do is figure out how do we treat myself or my partner or my parents or our children in the best way that's reflective of what they need and what they care about. And one of the things that we do great in this country is come up with new innovations and therapies and treatments. But one of the things that we don't always have a lot of information on is how does that therapy, that treatment, that intervention actually apply to you, right? And how does that apply to you, and why is that different how does that apply to me, right? Because you're different than I am, right? You're an individual person, you have different values and circumstances and different goals that you're shooting for than what I have. And that is really what PCORI is set up to do. We are the country's leading funder of comparative effectiveness research. And what that means is we compare various treatments to each other to kind of see, okay, which one works better than the other, or which one works better for you or for me, which setting is more effective, what's the best way to communicate this information to you so you can make an informed decision. So these are the things that we try to do, is take all the various options that are out there in the healthcare system now, all the things that are happening, all the things that we know work to a certain extent, and figure out how do we make that work better for the patient or the consumer or their caregiver. So since our inception in 2010, we've now funded over 700 projects and invested over $2.4 billion in this type of research. And we're now at that part where in our lifespan where we have a lot of research results now that we can talk about. One of the things that we wanted to do, and one example of our work that we've partnered with Men's Health Network on and a lot of others is, there's a lot of conditions and treatments out there that affect men differently than women, and what are things that we can do to capture that information in the research itself, since, most of you guys probably don't know, but, when we're looking at a research that gets approved by the FDA, that trial is probably pretty narrow, and it is limited to a very targeted population, and it doesn't always reflect what happens in the real world, right? So, as I mentioned, I'm a 30-year-old Asian man, what affects me, a treatment or a therapy that affects me may be different for someone who's 50 and a woman, right? So one of the things that we want to capture is that difference, So one of the things that PCORI does is take into account the effects on different genders, men, women. We look at the different effects on different populations, whether it's African Americans or Asian Americans. And definitely we look at different subpopulations, whether it's genetic diseases, other disabilities, or other individual differences. Those are all things that we look for when we do our research, so we can actually have a more robust evidence base to provide patients and their caregivers when they have to make decisions. Our job is not to help actually make those decisions for them. Our job isn't to set the policies. We obviously have great partners within the federal government and as well, and our job isn't to tell a doctor what to do, right? Our goal is to generate enough evidence so when you guys have to go to the doctor and make that decision, you guys are armed with information to make the best choice that's relevant for you. And one example that I'll talk about that we did partner with Men's Health Network on a few years ago is on prostate cancer. We funded a couple studies, as Dr. Brenholtz mentioned earlier. There are a lot of various options now, treatment options for prostate cancer for men. But they all come with different side effects and risks, and they all come with different benefits. So what we wanted to do was do a study to kind of say, okay, what are those benefits and risks of these various options, and based off individual preferences, what decision do you want to make? So we looked at studies that kind of compared radiation to surgery to active surveillance, and just said, if you do this is where you're going to get over the next couple of years. If you do surgery, this is where you're going to get. If you just actively wait, depending on your preferences, this is the likely outcome. And our job, again, wasn't to say this one is better and you should only go in this option A. Our job was to say, here are the benefits, here are the harms. And what we did was work with patient groups and provider groups like Men's Health Network and the American Urological Association, and came up with an evidence update, as we call it, and those are in your packets that kind of are meant to be useful for men when they go to the doctor and they have to make the tough decision on what option do they want to pick, as they treat their disease. And for some folks, it's like You know, I have cancer in me, I want it out, and that's fine. Here's the information so you know what likely symptoms and outcomes you may have. For others who may be a little, you know, a little more risk averse there or less risk averse, they're like, okay, I know prostate cancer is a slow-moving, slow-progressing disease, and I don't want to have to risk all these side effects that come with active treatment. So I might wait, and we'll work with my doctor to progress, and we'll treat it or we'll deal with things as things move forward. But those are choices that patients need to make, and they need evidence to make that, and that's what PCORI is really set up to do. And that's also, you know, this study and this example also kind of plays into why we're unique in the system as a research funder. You know, most organizations will fund research. They will go ahead and do the study, get published. Great, now we're done. You know, PCORI is different in this side of things. We don't stop there. Our mandate was to improve health outcomes and change practice, which is broad and tough to do because we don't also control every aspect of the healthcare sector. But one thing that we can control is when we do know that there is actionable, implementable evidence out there from our studies, we will work with the stakeholder partners, whether it's patients, caregivers, providers, policymakers, to do our best to implement them so that we do see practice change, we do improve health outcomes. And we're about 9 years old now, you know, and we're at the part where we do have a lot more research results, and we are seeing, you know, stakeholders take up our work, and we're seeing practice changed. So for us, we were funded for 10 years, which is great, but that 10 years is expiring on September 30th of this year, so we are working with Congress and other policymakers and organizations like Mental Health Network to help policymakers like yourselves and your bosses understand what's the value of this type of research, so that we hope to receive another 10 years to continue doing this work. So I appreciate the invitation, and thanks for having me here.
All right, wonderful. We're going to open this up direct for questions. So if anyone has a question, please raise your hand. Yes, back. No, you just have to speak up, please.
Okay. This is for Dr. Arnold. Sorry, I couldn't do that. So I know you're with Morehouse College, and I want to ask you what efforts are being carried out at Morehouse College to outreach, to create some sort of outreach program directly at young men at your school?
Well, Morehouse, it's actually Morehouse School of Medicine. Morehouse College carries the same name and it's affiliated. But at Morehouse School of Medicine, one of the things that's being talked about a lot is to try to use sports medicine and to try to make a bridge with young men, to try to get them to continue to be involved in the healthcare system. One of the good things about Morehouse that I've enjoyed about working there is that they're heavily focused on primary care and also the care of underserved populations. So the point is that it's really a question of trying to build a connection with the healthcare system, and we've been actively involved in doing screenings at places like churches and sports events and places where men have a lot of access to. One of the things that has a lot of promise is barbershop screening, because that's one of the places where you can get a lot of men who are sitting around, don't have anything to do. You can check blood pressure and things like that. As a physician, I don't believe in a waiting room. I believe in an education room. I believe it should be active, and we should be giving people information while they're waiting to be seen. But a barbershop is another area where you got waiting time, and then you have an opportunity to do education. You have an opportunity to do, you're not going to do blood work, obviously, and things like that, but you have an opportunity to do certain types of screenings in that setting. So barbershop outreach is one of the things being contemplated.
Any other questions? Okay, well, let's thank our esteemed panel. And they will be here for a little bit longer in case anyone does have any questions. We also want to thank our congressional members for sponsoring this briefing for us. If any of your bosses are interested in working or joining the Congressional Men's Health Caucus, please reach out to Taylor Hill from Congressman Mullen's office or to Stephen Schultz from Congressman Payne Jr.'s office. We thank you again for joining us.